Well, wonderful. Thank you for being with us this evening. Today is the second of our Life After Stroke webinar series. My name is Ahmed Koryat, and I am the CEO at FreeOx Biotech. I'm truly delighted to be here with you tonight for this important discussion about life after stroke, recovery, and the support that's available for the patients and their families in the context of post-stroke. At FreeOx Biotech, our mission is to deepen our understanding of stroke and to contribute alongside clinicians, researchers, and patient organizations to improving the care pathway of people affected by this condition and these unpredictable events. We're a clinical stage company working in the field of emergency stroke treatment, but today it is not about our products. Today is about the people, their stories, and what recovery truly looks like after such a life-changing event like a stroke. Um, we would really like to thank and show our appreciation to our partner for this stroke, our special partner, Freno Alictus Foundation, whose commitment to awareness, prevention, and patient support has been invaluable. Their involvement is key to making this webinar series possible, and most of all, to supporting patients, so many patients that have been affected by a stroke in their life. Um, Today, we have a very special panel, and we are honored to be joined by two exceptional speakers. I'd like to start with Javier Martin, who generously agreed to share his personal journey. Javier survived 3 strokes and spent several months in rehabilitation. His testimony is a powerful reminder of the challenges, progress, and resilience that shape the lives of people after stroke. Javier, my deepest gratitude and our deepest gratitude for sharing today your journey with us. And the second special guest is Dr. Gina Schwartz. Gina is our chief medical officer at FreeOx, but she's a reputable neurologist and an expert in brain disorders, including stroke. She will walk us through what happens in the brain during a stroke and after stroke and the different phases of recovery that can be described. Thank you both for being here with us today.
Thank you, Emmett.
So, today's agenda. During this session, we'll cover what happens in the brain during a stroke. The second section will be the acute and post-acute phases of stroke care. The third part, an important one, is Javier's personal testimony and a central moment in this webinar, how sharing with us his journey. The fourth part will be why the damage can persist even after timely treatment. And then we'll talk about all the reasons we have for hope and the ongoing scientific progress that exists. Although limited, there's still, some things happening. And finally, a Q&A session where we'll be happy to flag any questions you may have. So without further ado, I'll pass the mic to Gina for what happens during a stroke.
Thank you very much, Emmett. So, as you can see from this slide, stroke is a very common cause of acquired disability. In fact, it's estimated that every 3 seconds, someone somewhere suffers a stroke. A stroke-like episode comes on very suddenly, in an instant. It is unpredictable and requires urgent treatment and a necessity to get the person who is experiencing that stroke-like event to the emergency room or to the hospital, without which the effects of the stroke can be very severe, profoundly severe, and sometimes can even result in death. So, what actually happens in the course of a stroke? We talk about different kinds of stroke. The majority of strokes occur when there is a blockage or a thrombus in a blood vessel in the brain, and this is called an acute ischemic stroke. And you can see about 85% of strokes happen in this way. Most of them occur in smaller vessels within the brain, but a significant proportion also occur in the large blood vessels that supply large areas of the brain, and because of this, cause a significant amount of damage. In addition to what we call thrombotic strokes, we also sometimes see, less commonly, but not infrequently, bleeding or hemorrhagic strokes. And what we're talking about today, though, are the thrombotic or clotting types of strokes, where intervention is able to make a difference, but there is a strong need to do much more and go further. So if we move on to the next slide, this is what we talk about when a stroke occurs. We talk about the main or primary area affected by that clot in the blood vessel. There's no oxygen, no cellular supply to the brain cells, and as a result of complete oxygen deprivation, the cells die, and these cells cannot be rescued. However, around that area, we have what we call the ischemic penumbra. Ischemia means reduction in blood flow, not complete obliteration. So this tissue is injured but viable. And this is where we target our acute interventions and our treatment, because the quicker and the more productively we can save this tissue, the better the outcome for the person experiencing the incident. Then, further afield, further from the clot, we have what we call the oligemic zone. And here we have some reduction in blood flow, but this area of tissue is still viable. It still survives because there is very important collateral circulation. So, understanding these zones is essential because our treatment strategies aim to rescue the penumbra and prevent it converting into infarct core or dead brain tissue. So if we look at the next slide, when an acute ischemic stroke strikes, however, despite the very best intervention, 50% or 1 in 2 survivors can be left with permanent long-term disabilities. So, what are the acute phase treatments? Or rather, actually, very important. It is essential to intervene as quickly as possible when somebody suffers from a stroke. And we talk about time being equivalent to brain or brain health. You need to be able to recognize the signs of a stroke, which can impact the face, the eyes, with weakness or loss of sensitivity, weakness in the arms, in the legs, slurring of speech, or in a disability or inability to understand. And when these signs are spotted, either by a person themselves or by someone else, it is essential that acute medical care and intervention is obtained. Otherwise, the area that is being compromised cannot recover. So, what do we do when somebody gets to a hospital or a unit in which stroke is treated? Well, we have a very short time frame in which to intervene. We know that in the first 5 minutes, core neurons begin dying, and within the first 15 to 30 minutes, that ischemic penumbra, that potentially salvageable tissue, starts to develop. Within 1 to 3 hours, that penumbral area can shrink down. And this is really important in terms of defining the time frame in which current interventions are employed. After about 6 hours, there is minimal salvageable tissue because any potential recoverable tissue in that ischemic penumbra has died or is not salvageable. So it's really important that stroke is recognized, people are transported to a unit where medical intervention can take place as quickly as possible so that the best possible outcome can be affected and people can hope to recover fully. Of course, that being the aim. So on the next slide, we demonstrate how stroke is currently treated. And because it's a very acute event, of course, as I've explained, the interventions also have to be acute. So the one process used is to break down or dissolve the clot in the blood vessel using what we call thrombolytics or anti-clotting drugs. Now, these have a time frame around about 4 to 5 hours in which they can be effective, with a success rate of around about 30 to 40%. And people who are treated with thrombolytics have an outcome of around about 40 to 50% of patients experiencing independence after the event. Over the last decade or so, we have, as a medical community, been able to employ mechanical thrombectomy or endarterectomy. So, this complex phrase refers to actually going into the blood vessel using a device to break down and pull out the clot. So, you remove the obstruction in the blood vessel and restore blood flow to the area. Again, this has to be done very quickly, ideally within the first 4 to 6 hours. But as we become more experienced and are able to stabilize people better, we can do these processes within the first 24 hours. In the right patients, because unfortunately not everybody is the right person to have this mechanical thrombectomy, the success rate can be significantly enhanced, up to 70 to 85%. But when we look at the long-term outcomes, we still don't see a significant response, with round about 45 to 48% of patients returning to full independence. So there is still a huge amount that can be and should be done to promote beneficial, productive responses or outcomes in people who experience a thrombotic stroke. So, if we look at what happens after the stroke in terms of patients' recovery, some people are able to recover well, some people not at all. And we use, particularly in clinical research, but also in clinical treatment, the following scale. This is called the modified ranking scale, and we apply a score from 0 to 6 in terms of the degree of disability that that person depicts. If someone has a modified ranking score of 0 to 1, that implies that they are absolutely fine and have no significant functional disability. A score of 2 indicates a mild degree of disability, but these people are still able to live independently. However, once you get beyond 3, there are increasing levels of functional disability and increasing assistance in function, speech, behavior, activities of daily living, cognitive processes. So, what we're aiming to do with our novel interventions in the stroke space is return all people who have suffered from an acute ischemic event to a ranking score of 0 to 2 so that they can live, get back to how they were prior to the stroke, continue working, engaging with life, enjoying their families, and everything else that makes their life worth living. So I think now we'd like to hand over to Javier, who has very kindly agreed to come and talk to us this evening or today about his own personal experiences, the journey he has been on, and why it is so important that we as researchers and clinicians engage with people like him and the broader community to really drive forward factors and therapies that will make a difference in this very important space. Javier, I hand over to you.
Okay. Well, my name is Javier Martín. I live in Madrid. I'm 33 years old and work as an engineer in a multinational wind energy company. Well, now I didn't work because I can't work. On 8th of June of 2023, at the end of my running training session, I start to drag my right leg and quickly alert my teams, my colleague, that something was wrong. Fortunately, one of them have a mobile and call to emergencies. Also, again, luckily, one of them remembered a first aid course he had taken at his company, and as soon as ambulance arrived, the stroke protocol was applied. The same night, when I was in the hospital, I suffered the second stroke, but since I was already at the hospital, they reacted very quickly. And I had life sequels. Even so, they left me in the ICU, intensive care unit, because it was very strange since I did know what could cause it. My veins were clean. I had no cholesterol. I was super healthy and fit. I had run a marathon at the end of April, just 2 months earlier, and they couldn't explain it. So, since I had life sequels, I talked with the assistant, with the nurse. I was like in a hotel, but monitorized, covered by cables. On Sunday night, the 8 p.m. check passed, and everything was okay. My family already go home, and I start to read a book. The night shift nurse came while she was making her ponytail and say, "Hi, Javi, we are going to have a quiet night, aren't we?" I didn't answer her anymore. I couldn't speak. I looked her with panic eyes and make a signal with my left hand. I don't know how long it took from the time I had my third stroke until they reacted. This same night, they called Anna, my wife, to ask for her authorization for place me and stent in my brain. This time, the stroke left me many bad sequels, but fortunately, now the physical ones are hardly visible from outside, and little by little, I'm improving the cognitive sequels with a lot of effort and hard work. In fact, this is a therapy for me because I had never spoken in public, let alone in English. So it's horrible for me. That was
You're doing very well, Javier. Javi.
Thank you. That was the beginning of our particular marathon, and say our because the stroke didn't just happen to me. It happened to the whole family, but especially for both of us, my wife and me. My wife, Anna, was devastated at first. She couldn't believe it. Nobody could. But Jorge, my oldest son, said to her the next day, well, these are the cards we have given. There is no point in complain. Let's play the game as best we can. We have to work very hard and try to recover as much as possible. To have to put on our best face and spirit for help to help that he can see us down. At first, I didn't realize anything. I was in shock. For a week, I want to deny the evidence. I just say the word vale in Spanish. I couldn't say anything else, just smile. At night, my sister and my brother-in-law stayed with me so Anna could rest because she was all day with me at the hospital. A week later, I almost had surgery for appendicitis because I developed an internal hematoma as a result of the strain placement. Since I couldn't move, all the blood accumulated around my kidneys. But even though it hurt, I didn't complain. I didn't want to bother anyone. I had already caused enough troubles. So when Anna discovered this, she obviously got angry with me and gave me a sermon. She is my own Lieutenant O'Neill and say, this is not the way forward. If we don't all push in the same direction, we don't make any progress. What do we do then? So after a week in a turtle mode, I reacted. I had no choice but recover. I couldn't leave Anna with 3 children and a vegetable husband. I had to focus on recovering and doing so soon and doing so as quickly as possible. I spent 21 days at the clinic hospital until the hematoma was reabsorbed. From there, I went to San Jose Hospital. I have always had a problem facing mentality, so I didn't have time to cry. I started working on that. I could doing exercise with my mouth, trying to stand up. This is one of the reasons why I left my wheelchair just 1.5 months after arriving at San Jose Hospital. Such was my obsession with recovering that on my second night in San Jose, I want to transfer by myself from the bed to the wheelchair on my own. I didn't break the wheelchair and fell, breaking my subscapularis and supraspinosus tendons. But I was hemiplegic. I didn't realize until months later when I started rehabilitation for my arm in CEADAC. After 2 months in San Jose, I was discharged, not because I had recovered, but because they need a bed for other patients who were worse than me. My wife managed to get me evaluated and gave me a place at CEADAC. CEADAC is the State Center for Brain Damage Care. You know CEADAC? No.
By name, but not intimately.
It's the best place for the um, brain damage. It's like a university. You have a schedule. You have physiotherapists. You have logopedists. You have neuropsychologists. You have everything for physical and cognitive therapies. So I spent 7 months in CEADAC, and the same. I was discharged because other patients worse than me need the place. The problem is that only 120 places per year. So they have to manage these limited places, and it's horrible because it's not possible recover completely. You have to I don't know how to explain. Is if I try to they have a simulator of a car for and recover your ability to drive. It's amazing, and they have a lot of robots or machines that help to start to walk. I don't know how you say exoskeletos. You understand?
Exoskeleton.
Yeah.
Es lo mismo.
Mhm. It's amazing. Even for the hand, a lot of machines are incredible. The problem is that only one center in Spain. And this is my experience. Sorry for my English, but
Oh,
Your English is excellent.
Xavi,
no,
your
no.
your
Please
English
don't
is perfect.
apologize. You're
I,
doing,
Very good.
doing well.
Thank you so much.
I lost my English. I lost my signature. I lost my capacity of how do you say organizing and my abilities as an engineer that uh, I use every day. I lost
Mm.
everything.
It's part of them came back, and you're very courageous man, and thank you for this. I have really literally tears in my eyes. Thank you so much for being here.
So Javier, how long did you stay in the rehabilitation center? You said several months, is that right?
In CEDAC from September to April, 7 months. In San Jose, 2 months.
2 months, yes. And how how much progress would you say you were making during that time? Was it an even course or was it slow and then
Mm,
quicker?
The
How did
the
you gauge your ability to recover?
yes, in San Jose was
Hmm.
mainly physical,
Yes.
and I discovered that I lost my signature when I went to sign the I don't know the fianza for
Hmm.
I don't know in English fianza for the wheelchair. In order to get out the center, I have to sign the a paper in order go
Caution. We call it the caution in English.
the,
Caution.
the caution.
Caution in French. It's
Yeah,
actually caution. I don't know.
for when I have to go to the hospital for check my because my stroke was uh, provoked by vasculitis. Is is a autoimmune
Continue.
illness. My defenders attack me, and
Hmm.
my attack in a vein in my brain.
Yes. So from a medical perspective,
Mhm,
we frequently see, especially in younger people, that something like a vasculitis or an
mhm,
autoimmune illness,
yeah,
where the smaller blood vessels develop clots
mhm,
because you have a lot of inflammation going on in the
yeah.
blood vessels, which stimulates the clotting mechanism, so makes clots occur. So I think, what anybody listening and seeing you can get from this is that stroke strikes anybody. It's not just an issue, as you say, relating to high blood pressure, high cholesterol, inactivity. There are many other factors that can come upon one. Many times people are not aware of them. And that's also why there's such an imperative for us to be able to do more so that anyone who has a stroke, we can ultimately turn around and say, you are going to be okay. That is our hope and that is our aim. But from your perspective, what do you think we as scientists and clinical people in the space should be focusing on? What would make a real difference, or what do you think could have made a real difference to you? I know
Mm.
that maybe that's a hard question.
Well,
Sorry.
no. Now is easy to say, but the problem is the first one is accept the problem.
Mhm.
If you don't accept this is my first advice. If you don't accept, it's impossible recover to start the recover. So this is my how do you say turtle mode. My first week in turtle mode, and when Anna let me the 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 sermon, I reacted. This is the
And
first.
you went in Jaguar model.
Sorry.
You went in Jaguar model. Jaguar, like a jaguar. You went very fast, the fastest
Well,
animal. The
not Jaguar,
turtle is
but
the slowest one, and you became a jaguar.
yes, I reacted, and this is the first one. And from this point, you can start to recover, and the recover is not easy.
Mm.
It's not easy. You have to work, 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 and work, and the result maybe don't achieve your the result you expect, but for sure if you don't work the result don't arrive. So my second recommendation is to work, and work, without when I was in CEADAC, sometimes I don't achieve the objective of the therapy, and these times give me how do you say
Motivation?
no
No.
me hacían estar
En castellano, ¿cómo lo dices?
eh, joder, perdón.
No
No
problema.
pasa nada.
Me generaba ansiedad.
Ansiedad. Anxiety. It caused you
Ans-
anxiety because you didn't
Anxiety.
get the results you were expecting.
Yes.
Mm.
And they give me a pill, extra pill, for control my anxiety
Mhm.
and get the objective of the therapies, because my mentality was focused only in recover. But when I don't achieve the objective, I was frustrated, and they give me a pill for controlling this frustration. And from this moment, well, when this pill start to take effect, I increase my recovery.
Well, on that note, I, I think we'll return back to our presentation
Yes.
because we still want to talk about why damage persists after the acute event, but why we are hopeful in the work that we're doing that we can make a difference so that someone like yourself who has an acute stroke does not have to suffer through months and months and months of rehabilitation. What our aim is to do is to intervene as quickly as possible and most effectively as possible so that as little tissue, brain tissue, is damaged so that the process of recovery is easy and smooth, both from a physical, cognitive, but also, as you've clearly mentioned, from an emotional point of view.
Yeah.
So very briefly, and thank you so much for illustrating all of those points so brilliantly. So what we were going to mention now was why the damage persists after a stroke. And what we tend to see and what we think we understand at the moment is that it's not just the fact that there is a clot in a blood vessel and blood is not getting to the tissue. But in addition, when we unblock an artery using something like mechanical thrombectomy or thrombolytic agents, anti-clotting agents, we allow for oxygen to return to tissue that has previously been without some oxygen. Unfortunately, this results in some issues that can cause problems. So when this happens, there tends to be a flood of blood into the area carrying what we call oxidative stresses or reactive oxygen species, harmful molecules that can also damage the cells, the linings of the blood vessels, and blood and brain tissue. In addition to this, there are still small blockages, very small, what we call microvascular blockages with ongoing inflammation. And this still prevents that blood flow reaching the tissues that can be rescued. One of the issues is that the very small capillaries and the venules can become or remain obstructed because of swelling, fragments of the initial clot, and injury by the white blood cells and the inflammatory cells, which in a way are trying to help get rid of the damage. So these immune-mediated responses can actually add to the damage. And these processes explain why many people remain disabled or non-functional despite removing the clot successfully. So it's not just removing the clot, but it's targeting all these additional factors that is really, really important and where we are concentrating at the moment. And we think, if we look at the next slide, that what this will enable us to do is we will be able to improve on the intravenous thrombolytics, improve on the thrombectomy or the clot removal, and certainly do better than all what we call the neuroprotectant strategies that researchers have used or devised in the last 10 to 20 years that have not been able to save or salvage the brain tissue effectively. So if you look at the next slide, we are looking at intervening to target the microvascular components, the inflammation, the oxidative stress effectively, so that we deal with the reperfusion injury, the injury that comes about when we remove the clot and there's an inflow of blood and harmful mediators into the salvageable tissue. And in so doing, we are aiming to generate improved independence and higher rates of functional recovery. We also are aiming to reduce the growth of the infarct or the dead tissue, so we have less brain tissue loss. And at the same time, we are very careful that what we do is safe for the person or the patients, because we obviously don't want to intervene and cause additional factors that are harmful to the person in the acute phase or for their long-term recovery. So that is what we, as researchers and drug developers in the space, are very much trying to do at the moment. In order to generate this data, we are aiming to run a very big and what we hope will be an impactful clinical trial with a new agent in the new year, which we hope will redefine stroke care by reducing disability rates and improving significantly quality of life for people who have suffered from a stroke. So with that, I'll conclude my part of the presentation, and I think we can open up the floor to questions to all of us, particularly to Javier, who we'd like to thank once again for explaining this very sad but inspiring story and showing us the resilience, the determination that has allowed you to recover and return to a life that is worth living. You are a very good example to all of us as to why this is so important. And it really incentivizes me, and I'm sure many others, to carry on doing this critical work so that we can really make a difference for people who experience a stroke and facilitate their complete recovery.
Well, thank you. Thank you, Gina. We already at 7:15 p.m. even, so we won't have too much time to take that many questions, but maybe one. Javier, you were in rehabilitation for about 9 months, from what I understand overall. And so, Gina, what are the factors that influence how well someone recovers from, what does research show us?
Well, there are many factors that relate to the stroke itself. So it depends on the size of the stroke, the site of the stroke, the extent of the damage, and of course that often links to the time taken to intervene and the type of intervention used. Obviously, the underlying health of the person involved plays a role. And obviously, if you are more resilient, you have the wherewithal to recover. But I think what's really critical and what Javier has exemplified is that recovery is very much dependent on the ability to pursue the recovery. That people must be engaged, they must be incentivized, they must be supported. And you again heard from Javier that in all of Spain, there's only one center available. So for the tens of thousands of stroke patients, there are only a very select few who can engage in such a wonderful rehabilitation center, which will incentivize them, motivate them. I think I use that word. Bring them up when they're feeling anxious, down, depressed, stressed, overwhelmed, because all of this is critical. So it's very much about the kind of stroke, the mindset of the patient and the whole team and the family and the
Yeah,
caregivers and the community around them, but also what we are trying to do as medical researchers is give all of these component parts
yeah,
a better chance by devising a therapy that will kickstart the process and bring them out of that acute event quicker, more effectively, so they can start that rehabilitation journey and get back to a wonderful quality of life that they experienced prior to the stroke.
Thank you, Gina. Thank you very much. Thank you all for being here. And Javier, thank you so much for your inspiring story, and wishing you, the best of luck, and sending you all our, best support and energy. And we'll definitely be stay in touch. Well, it's time for me to say goodbye in the name of all our panelists and the whole team at FreeOx and Freno Alictus, and invite you for next week, next Tuesday, for next webinar in our series Life After Stroke. And this time we'll have Dr. Adnan Siddiqui, who is a world leading neurosurgeon from the Jacobs Institute in Buffalo, New York, who will talk about the emerging treatments for stroke in the emergency setting. So, without further ado, have a wonderful evening and see you next week. Goodbye.